This is Ian Botchard.
And Liang Liu.
And welcome back to the Clinical Correlation. Today's case is...
This is a 50-year-old male with no past medical history who was brought in by EMS after a fall.
EMS told us that the patient had been drinking the night before and fell from standing onto a carpeted surface.
His father was home and tried to pick him up from the ground but was unable to do so and left him there overnight. The morning after, when he was still unable to get up from the floor, his father called EMS.
On arrival, EMS reported the patient's initial blood pressure was 60/30, so a normal saline bolus was started.
After his bolus en route, his blood pressure responded well. It is now 117/84, otherwise his vitals are unremarkable.
EMS had reported in their exam upon arrival to the patient's home that the patient was unable to move his upper extremities and had minimal movements in his lower extremities. However, on ED presentation, the patient was unable to move his lower extremities at all and unable to lift his arms from the bed.
He had C-spine tenderness and no sensation below the clavicles, consistent for a C6 sensory level deficit. Rectal exam revealed no tone and no perineal sensation. No step-offs or obvious deformities were noted to the spine.
He was maintained in a C-collar, and the remainder of his exam showed only scattered abrasions with no other signs of trauma.
On bedside fast, patient had no abdominal or pericardial free fluid, but check out his bladder.
That bladder looks pretty distended.
Definitely. In this patient, there was no need to measure the bladder volume as clearly it was distended. But if there was any question, it is important to obtain 3 measurements of the bladder to determine the volume. First in longitudinal view, where the bladder looks like a loaf of bread, and then in transverse view as depicted here.
The patient was taken for a CT of his full spine. Here are his images of the cervical spine. You will see that there is stenosis of the spinal canal at C4 and C5 due to disc bulging. The C5 vertebral body is also abnormal, which is consistent for a mildly displaced fracture.
He was then rushed to an MRI. The MRI again showed a C5 vertebral body fracture, though not depicted on this image. There were disruptions of the anterior longitudinal ligament at C5 and injury also to the interspinous ligaments extending from C2 to C6. Additionally, you can see severe narrowing of the central thecal sac from C2 to C6 with cord edema and loss of normal cord morphology. This is concerning for acute cord injury.
You can see in this MRI image normal cord signal in the thoracic spine shown here.
The cervical spine is composed of 7 vertebrae. To read spine images, keep in mind the normal alignment of the spine.
In this normal lateral x-ray of the neck, you can see the spine is composed of the anterior spinal line, posterior spinal line, spinal laminal line, and spinous process line.
In evaluating any fractures, it is important to determine whether the fracture is stable or unstable. This is critically important as patients require emergent operative management in the setting of unstable cervical fractures.
The mnemonic Jefferson bit off a hangman's thumb can be used to remember the unstable fractures.
Jefferson is for Jefferson fracture, which is a C1 burst fracture, which can be due to axial loading on the back of the head or hyperextension of the neck as seen in diving accidents.
BIT is for bilateral cervical facet dislocation, which generally occurs due to a hyperflexion mechanism such as a rapid deceleration.
OFF is for odontoid fracture, and specifically type 2 and 3 are unstable. This is also known as a Dens fracture and is a fracture of the odontoid of C2. This can occur with injuries of flexion or extension.
A is for Atlanto-occipital dissociation or fracture, which is also known as an internal decapitation. These injuries are severe and associated with high impact mechanisms of injury. The injury results in a disruption of the stabilizing ligaments between the occiput and C1 vertebral body. This injury not only threatens the spinal cord, but also the brainstem.
HANGMAN'S is for a hangman's fracture in which there is a bilateral C2 pedicle fracture resulting in anterior displacement of C2 on C3. This is due to forced hyperextension of the neck.
Thumb is for teardrop fracture, which is typically sustained with shallow water diving injuries or MVC decelerations in which there is severe flexion of the spine. This results in displacement of a teardrop-shaped fragment of the anterior-inferior portion of the superior vertebrae. There is also posterior displacement of the vertebral body and disruption of the posterior longitudinal ligament.
With unstable fractures, the spinal cord is at risk. While some injuries result in complete cord transection, a significant number of patients present with incomplete spinal cord injuries with characteristic findings on exam.
Though injuries do not read textbooks, and each injury affects a unique section of the cord, traumatic spinal cord injury patterns can be generalized into 3 syndromes: anterior cord, central cord, and Brown-Séquard syndromes.
Anterior cord syndrome is due to flexion injuries or decreased perfusion. There is loss of motor, pain, and temperature below the sensory level, with preservation of the posterior column responsible for proprioception.
Central cord syndrome is associated with hyperextension injuries, as in the case of whiplash. This results in both sensory and motor deficits, with arms more affected than legs.
Brown-Séquard syndrome is classically associated with a stab wound and characterized by loss of motor function and proprioception on the ipsilateral side, with contralateral loss of pain and temperature due to how the fibers cross in the spinal cord.
Sometimes we hear spinal shock and neurogenic shock used interchangeably. This is incorrect. Spinal shock is what occurs when the spinal cord is stunned. Think of this as a concussion of the spinal cord. Patients have transient neurologic deficits.
Neurogenic shock, on the other hand, is the loss of sympathetic innervation from an injury to the spine. This occurs due to injury to the cervical or thoracic spinal cord, resulting in bradycardia and hypotension.
Injuries above T1 result in full sympathetic denervation. If the injury is between T1 and L3, it will result in partial denervation, and if it's below L4, there is no sympathetic denervation.
Patients will be warm due to peripheral vasodilatation, with hypotension due to unopposed parasympathetic or vagal tone. This is a diagnosis of exclusion, as patients can have hypovolemic, obstructive, or cardiogenic shock as well after trauma.
Mainstay of treatment for neurogenic shock are crystalloids and vasopressors. Norepinephrine is first line and should be titrated for a MAP goal of 85 to 90. Phenylephrine can be added if hypotension is refractory. A discussion on cervical spine injuries would be remiss if we did not discuss decision-making roles. Keep in mind that not every blunt force injury requires imaging. The Nexus and Canadian C-spine rules are helpful decision-making tools to decide whether to scan or not to scan.
In addition to bony, soft tissue, and spinal cord injuries, think about vascular injuries in these patients, especially if there is a discrepancy between the neurodeficits and the level of injury, a seatbelt sign across the neck, or a bruit heard on exam.
Our patient was taken emergently to the OR for C2 through C7 posterior cervical decompression and instrumented fusion.
He tolerated the procedure well. He was maintained on 2 days of vasopressors with a goal MAP above 85.
By hospital day 5, he was transferred to the inpatient rehabilitation center.
He continues in rehab to this day and has gained some anti-gravity movements in his lower extremities and has increased strength in his arms.
To summarize, remember your Nexus and Canadian C-spine rules. Have a low threshold for imaging, as missed injuries can be devastating.
Polytrauma patients are at risk for distributive, cardiogenic, and hypovolemic shock, so neurogenic shock should be a diagnosis of exclusion.
Consider vascular injury, especially in the patient with a seatbelt sign across the neck, cervical bruit, or discrepancy between the level of injury and neurodeficits.
And keep in mind the mnemonic, Jefferson bit off a hangman's thumb, for your unstable fractures, as management is distinctly different for these patients. So that's it for this case.
Send us your comments, suggestions, and cases to theclinicalcorrelation@gmail.com and follow me on Twitter @MDNotified.
Thanks for listening.